Hello everyone, I am Dr. Akansha, Assistant Professor in Department of Neonatology at SGPGI Lucknow. So this is the second part of the session on physiological basis for principles of neonatal resuscitation. And in this lecture, the specific learning objectives of this presentation would be to discuss regarding thermoregulation in neonatal resuscitation and special emphasis on the resuscitation of preterm babies. So, thermoregulation by providing warmth is the key initial step of neonatal resuscitation because a newborn is most prone to hypothermia at the time of the birth. We have made phenomenal strides in in the science of neonatal resuscitation over past 3 decades. Some of the aspects we have discussed in the previous lecture, including the crucial role of ventilation in neonatal resuscitation, about the judicious use of oxygen, approach to meconium-stained amniotic fluid, and the rationales for chest compression and medications. In this lecture, we would be focusing on some other aspects such as deferred or delayed cord clamping and about the provision of positive end expiratory pressure or PEEP or CPAP as we call it in the delivery room. Preterm infant is a special set of neonatal population who are at high risk of having complications at the time of birth and thereafter. So they require some additional resources and special consideration. So we would be focusing on the resuscitation of this cohort. They are more vulnerable compared to their term counterparts to hypothermia at the time of the birth, and in contrast to their term counterparts who are able to generate large positive and negative pressure breaths with their first few cries after birth, premature babies are unable to generate enough pressures to keep their alveoli open. So, for prevention of hypothermia in delivery room, as we already discussed, that it is a baby is most prone at the time of the birth to hypothermia, and hypothermia in itself is an independent predictor of neonatal morbidity and mortality. So, we must ensure keeping the baby warm at the time of the resuscitation, and sources of heat loss by all means, conduction, evaporation, convection, and radiation should be minimized for that. So, immediately after birth, the baby is wiped with a pre warmed towel or linen and is placed on the mother's chest and covered by a cap and blanket. It is important to wipe the baby because wet skin will promote rapid body cooling, leading to evaporative losses. And by placing the baby on mother's chest and covering them by a cap and blanket, we ensure that it will maintain the temperature of the baby, and it will help in the early initiation of breastfeeding also, that will act as sources of additional energy that the baby will get from the glucose. For babies who for any reason cannot be kept on the mother's abdomen or cannot be provided with a skin to skin care, they may be taken to a pre-warmed radiant warmer. So the warmer, it is important to keep the warmer on at least 20 to 30 minutes before the delivery on manual mode, with 100% heater output, so that the baby's skin or the baby's body does not come in contact with any cold surface to prevent the conductive heat losses. Uh, it is important to maintain the temperature of the delivery room or the labor room or the operative room between 25 to 27 degree Celsius, and it should be ensured that there is no drafts of air entering into the delivery area. So there should be no open windows or doors in the delivery room, and there should not be any fan in the labor room area to prevent any heat loss by convection. The baby should then be appropriately clothed in 1 to 2 layers of clothing, and covered head should be covered with a cap. So, though most of these measures are enough to maintain the temperature for the term babies and some of the uh, later preterm babies, but more moderate to late preterm babies, for them, we may require some additional resources or additional measures to ensure that they maintain their temperature in the thermoregulatory zone. It is recommended to use heated and humidified gases if at all required during the resuscitation of preterm babies, because cold and compressed medical gases may lead to significant losses of heat from the respiratory tract. It is now well proven that immediate and early kangaroo mother care should be provided to stable preterm and low birth weight babies, and it will not only help in prevention of hypothermia, it has multiple other benefits, including good rates of breastfeeding, prevention of infections, and better anthropometric measurements later on. Uh, if at all the baby needs to be shifted to the neonatal intensive care unit from the delivery room, so the babies should be dressed and then they should be dressed or appropriately covered and then placed preferably in a pre-warmed incubator, which is must transport incubator for the transport of low birth weight babies, or in case it is not available, a heated mattress may also be used to maintain temperature at the time of the transport. For even more premature babies who are less than 32 weeks of gestation, it is recommended, very preterm infants less than 28 weeks, less than 1000 gram, it is recommended to cover these babies immediately after birth. So, as soon as the baby is delivered, they are covered below neck with a polyethylene or a plastic food grade wrap, and the head should be immediately covered. So, this will prevent any evaporative or fluid losses, which may amount to a significant heat loss in these premature babies. So they should be immediately covered with a plastic wrap and they should be kept covered all throughout the resuscitation. Additionally, we may use a thermal mattress which can be put under the blanket or the mat of the baby on the radiant warmer, and then a chemical or a gel based transport mattress may be used if pre-warmed transport incubator is not available. Coming to the cord management strategies, so what is the plan of umbilical cord management at the time of the birth? So, for many centuries, we have practiced immediate cord clamping or cutting the clamping the cord immediately after birth. But multiple studies have now shown that there are multiple benefits of delaying the cord clamping. So it will provide the baby, whenever we clamp the umbilical cord, a significant amount of the blood is lost in the placenta. So if we delay it by a few seconds or few minutes, so one, the baby will keep getting the oxygenated blood from the mother through the placenta, which will act as an additional source of preload for the baby's heart till the time the pulmonary circulation is established and the pulmonary venous return is established. So it will not only provide baby with some extra volume of blood, it will also support the ventilation of the baby till the time lungs are able to take over as the organs of gas exchange. So it is now the recommended best practice by American College of Obstetricians and Gynecology in most of the cases. who advise delaying the cord clamping for at least 30 to 60 seconds for vigorous term and late preterm babies who do not require any resuscitation. Umbilical cord milking may be practiced when delayed cord clamping is not feasible, but it is not recommended for babies who are less than 32 weeks of gestation because it has been shown to increase the incidence of intraventricular hemorrhage and mortality. So, cord milking is not to be done for babies who are less than 32 weeks. So, coming to the benefits of delayed cord clamping. So, for term newborns with the extra circulating blood volume that we've got from the placenta will result in a higher blood volume and a higher blood pressures and obviously a better hemodynamic stability. These babies have been proven by various studies to have a better hemoglobin at 4 months of age with lower incidence of iron deficiency and better iron stores. The only concerns with delayed cord clamping remain a slight increase in the need for phototherapy. There is no increase in the need to treat polycythemia. So there may be a slight degree of polycythemia, but it does not result in an increase in the incidence of symptomatic polycythemia, which requires treatment. And there have been no increase in maternal morbidity by practicing delayed cord clamping. So, a slight increase in need for phototherapy, but it has multiple more benefits in comparison to this. For preterm babies, again, this extra RBC volume is very, very important to improve their hemodynamic stability, leading to their higher initial mean blood pressures and thus lower need for inotropes. They tend to have higher hematocrits at 7 to 28 days of age. Thus, they may require less blood transfusion, which is a very significant problem in preterm babies, higher hemoglobin at birth and even at 10 weeks of age. And also, these babies have been shown to spend less time on supplemental oxygen, thus decreasing the incidence of chronic lung disease as well. And multiple theories are now, studies are exploring the role of delayed cord clamping in lowering the incidence of late onset sepsis in purview of some extra immune cells that get transferred to the baby, lower incidence of IVH, and improved neurodevelopmental outcome. So, there are multiple benefits of delaying or deferring the cord clamping at the time of the birth. Now, coming to resuscitation of preterm babies, they are more at risk of all the complications in comparison to their term counterparts. Already, we have discussed regarding the thermoregulation, and we also saw that early kangaroo care with skin to skin contact should immediately be started for stable preterm babies. Another important aspect of preterm resuscitation is the use of delivery room CPAP. We will see further in detail about this in the subsequent slides. Starting with higher inspired oxygen, as we saw that 21% oxygen is sufficient to cause pulmonary vasodilation for term babies, but we may require a slightly higher oxygen for this for preterm babies. And it is very, very important to handle these babies gently to prevent any neurological injury, to improve their outcomes, minimal stimulation, lung protective strategies, neurocentric, avoiding both hypo and hypercapnia for at the time of ventilation and resuscitation. So all of these will contribute to decrease the morbidity and mortality in premature infants if we take care of these at the time of resuscitation. So, talking about respiratory distress in preterm infants, we know that these babies are immature and their alveoli are surfactant deficient. Hence, they are prone to collapse or atelectasis. There is a very slow clearance of lung liquid at the time of the birth. Hence, they require more assistance at the time of transition. They have very stiff or non compliant lungs with compliant chest wall. So that makes the that increases the work of breathing significantly for these babies. They tend to have inherent ventilation perfusion mismatch, and thus, for to overcome all of these, early initiation of delivery room CPAP has been shown to decrease the need for mechanical ventilation and decrease in the mortality of preterm babies. So we see here that FRC, or the functional residual capacity, is the amount of air which is left in the lungs after a normal respiration. But in case of the premature babies, this FRC is less than the closing volume, the volume at which the airways tend to collapse. So when this FRC is less than closing volume, so after every breath, after at the end of every expiration, the alveoli will tend to collapse, and more effort would be required to reopen these collapsed alveoli in each breath, which would increase the work of breathing in these babies significantly. So, CPAP helps by increasing the functional residual capacity of these babies above the closing volume, and thus it may help in overcoming or decreasing the work of breathing. But having said that, it is important to remember that though an optimum CPAP, if we provide them with an optimum degree of positive end expiratory pressure, it will lead to a improvement in the lung compliance. By that, I mean that a change in volume per unit change in pressure. So at optimum PEEP, a very less amount of pressure would be required to bring about a change in the volume of the lung to decrease the work of breathing. And though with low FRC, we saw that the alveoli tend to collapse, but even if we provide them with high or much increased CPAPs, so that will lead to over expansion of the lungs, and again that is detrimental. It will lead to lung injury, and it will again worsen the compliance of the lungs. So provide an optimum PEEP at which the lung has the best compliance. So it is we learned that most of the newborns make transition to extrauterine life without intervention. Prevention of hypothermia in delivery room is a cost-effective, high-impact intervention to reduce the neonatal mortality, especially for preterm babies. Delayed cord clamping is recommended in vigorous term and late preterm infants, at least up to 30 to 60 seconds. Special emphasis is required when you are planning to resuscitate a preterm baby because of the anticipated risk of complications, and early initiation of delivery room CPAP should be provided with titration of the FiO2 as per the target preductal saturations guideline provided by the NRP. So these are the references. Thank you.